All right. Well, welcome welcome all, and thank you for joining us for this upcoming webinar called Growing Advocacy and Policy Efforts in Health Psychology, a Multi-Stakeholder Perspective. And this webinar is hosted by the Society for Health Psychology's Health Advocacy and Policy Council and co-sponsored by the Society of Clinical Psychology, APA Division 12. You asked, we delivered. This is a session that we did at the main APA sessions this year and now have made it available to you as a webinar for educational credit. My name is Kim Smuldren. I'm the chair of the Health Advocacy and Policy Council. I'm an associate professor at Yale University, and I will be joined by my co-host today, Valeria Martinez Kaigi, and she's with Override Health and Yale University and clinical psychologist. And Rochelle Hayes, she is an associate professor at Virginia Commonwealth University School of Medicine, also clinical psychologist. And before we start and announce our speakers for today, I will have a few household keeping items to go over with you. This and all our presentations are virtual, and they are offered to you as a free benefit of membership in the Society for Health Psychology. So we encourage you to invite your colleagues and students to join to make sure that you can make free use of future presentations and other society benefits. You can always check us out on the website at societyforhealthpsychology.org for more information. This event is being recorded, so anyone who speaks during this event or asks a question is agreeing to be recorded, and it's granting permission for the recording to be posted on our website. The webinar, as I mentioned, is eligible for 2 continuing education credits under the Society of Clinical Psychology Division 12 sponsorship. CE evaluation information will be sent through your email to all who attend the full presentation, and we'll send it out shortly after the webinar. We will leave the evaluation portal open for 1 week until 5 p.m. Eastern on Thursday, October 26, 2023. And then the CE certificates will be sent through your email within 5 to 10 business days after you submit the evaluation. And all participants are invited to submit feedback through this evaluation, even those who do not seek credit. We will save questions up until the end of the presentation, and you can submit them through the chat feature during the presentation. And we'll have the moderator call you at the end to unmute and ask your question. And so for now, I'm very honored to start introducing the first speaker of today. And the speaker will be Dr. Erin Swedish, clinical psychologist, and she currently is the Director of Health Integration for the Office of Health and Healthcare Financing at the APA Directorate. And she will be representing for us the APA Advocacy Office perspective. Welcome, Erin, and looking forward to kicking off this session.
Thanks so much, Kim. Let me just share my screen. Does everybody see? Can you still see it right now? Yeah, we're good. Okay. Hi, everyone. Thanks for having me. Like Kim said, my name is Erin Swedish, and I'm the Director of Health Integration out of the Office of Health and Healthcare Financing at APA. I just want to first start by saying I think we all know that the healthcare system is in crisis, and there's lots of contributing factors to this. We know the public health emergency definitely was a factor. The opioid crisis and substance abuse issues, the mental health crisis. Healthcare costs in general are skyrocketing. There's poor reimbursement for mental and behavioral health services, a lot of provider burnout, and workforce shortages, and then just sort of health inequity across the board. So we're kind of thinking, what are the possible solutions to this sort of healthcare system crisis? And we take, we really take a population health approach, and that the sort of whole population needs to be addressed instead of just individuals. We look at services needing to be expanded, increase access to services, and looking at oversight and supervision of services, so developing those more. Definitely looking at alternative payment models and how we're getting paid. And then finally looking at leveraging technology and what the future of technology looks like in our field. And of course, there's probably several others. In February of 2022, APA adopted a policy on population health and sort of its advancement in psychology and how to advance population health within the psychology field. And really what this, looked at, if you look at this sort of the population health approach, if you look at this triangle, oftentimes the top of the triangle is targeted within psychology and our services. So those with a diagnosis get treated, right? Well, in population health, we really want to look through this lens, a population health lens, whether it be payers, code reimbursement, really focusing on, what we're doing and treating the whole population and keeping them healthy. So this means that the work that you're doing, psychologists in health systems and inpatient, outpatient, is population health, and really looking at what interventions sort of fall in each part of this triangle. So like I said, at the top is sort of your traditional psychotherapy treatment that we do when someone is diagnosed with a mental health disorder. In the middle, though, we have other interventions such as screening for substance use using expert codes, screening for tobacco use using the tobacco codes. There's consultation codes that in this area, in this part of the triangle. So that at-risk population doing these screening things to really capture those people. And at the bottom is...
ask you to put your slides in presentation mode. So, sorry to interrupt.
Sure.
Down below. At the right line.
Yeah, down here.
There should be an icon.
I'm so sorry. Let's see.
To the right. Yep. That's yep. Perfect.
Is it?
Yes. Excellent.
Okay. So if I okay, good. So just making sure. So at the bottom there, it's really keeping people healthy and looking at how do we keep people healthy and what interventions fall into this. And recently, New York passed a change in the medical necessity guideline to include people getting help when they do not have a mental health diagnosis. So there are things like this that we really can approach the whole population. And the work that we do is, reaching at all of these levels, reaching people at all three levels. So again, reaching people earlier is really important. Earlier in development and working sort of further upstream to prevent unnecessary sort of suffering, and expanding these strategies used to address people's sort of diverse behavioral health needs. So another example might be utilizing public health and community-driven approaches that address social determinants of health. This is if you have to improve outcomes and you reach more people. Another important aspect of advocacy is how we get funded. How does clinical work get funded, right? And so, we're looking at alternative payment models, value-based care, affordable care organizations, and sort of merit-based incentive programs. So these are all in the works of looking at how clinical work gets paid. And then under fee-for-service, looking at increasing, expanding code access, looking at different codes that might be available for use. Also increasing reimbursement rate, or, looking at the rates that we're getting paid for different codes and how do we increase that. And then, like I mentioned in the previous slides, looking at that medical necessity guidance and see how, if we can, change that at different states to include, so people get the services they need without a diagnosis, a specific mental health diagnosis. So I think it's also important to look at what are other ways that, we bring in revenue as psychologists in the work that we do. So looking at quality metrics and indirect revenue. We all know that sometimes the revenue that you generate doesn't equate, right? And so looking at what are other ways that we know the work we're doing is improving the institutions and health systems that we're in. So for example, you could look at the top 10 ranked hospitals or in the US News Report and look and see that those all have a psychologist as a part of the department and use that data as a sort of quality metric. Also looking at, in transplant departments, physicians can only do the transplant after the psychologist has done an initial eval. So looking at these quality metrics and using those as an important piece as advocating for the work that we're doing within the health system. And then finally looking at RVUs and realizing that this is really a measure of clinical productivity, and that a lot of times RVUs sort of get clumped together, and that all psychologists are supposed to do this RVU. And it's just really important to be knowledgeable that RVUs can look different, and that if you're going to advocate for yourself, like really figuring out and being knowledgeable what that RVU should look like for you. Next is some work we're doing. We actually just formed a integrated specialty care advisory group, which is led by myself and Dr. Kim Smolderen. And this really is a development to sort of propel and have resources and advocacy around integrated specialty care and figure out what is needed to sort of make sure that we're advocating for these specialty care departments and how do we integrate psychologists in these areas. We have key divisions that represent in the group, and then we also have members from the Committee of Rural Health and Board of Professional Affairs. This group was just recently formed. We had our first meeting, and we plan to. It's a very exciting time. I think there's a lot of folks who are very interested to get this work moving. And then we also have a lot of federal legislation happening at the current moment. So this is just a select few, but just a few to point out. The one at the top, the ABDACT Act, is to develop a Medicare modifier that would allow doctoral interns and postdoctoral residents to bill for behavioral health care services provided under the supervision of a licensed psychologist. The next one, the Complete Care Act, it would improve access to effective mental health care in primary care settings. So it's really helping with the cost of implementing an integrated care model. We know that can be a huge barrier, the upfront cost of integrated care models. So that's a really important one. Well, they're all important, but and then lastly, the last one on there is Strengthening Medicare for Patients and Providers Act. This is actually bipartisan legislation that would actually tie the annual update to provider payment rates to the Medicare Economic Index. So this really makes it so that payments reflecting changes in the providers' expenses and sort of the broader economic trends that are happening. So a lot going on in the legislative world. Next is, so each year, the Centers for Medicare and Medicaid release a proposed rule, and it's on the following year's sort of Medicare physician fee schedule. And so this always includes changes in policy that will directly impact psychologists, patients, and everyone in their communities. And so APA always urges the entire discipline of psychology, whether you're a practitioner, scientist, student, whoever, to comment. The proposed rule usually comes out in July, and then the comments are due usually early September. And this year, we're happy to say that psychologists actually provided 10,182 comments. They actually made up sort of the lion's share of all comments submitted to CMS, and this was around 45%. And we actually had 47 SPTAs that, as associations commented, had a comment letter as well. And this is sort of a state-by-state total count of comments provided by psychologists. And then I'd like to end my presentation with a little slogan that my office has come up with, participation propels psychology. We just really feel like it's really important for our field that psychologists participate in advocacy and at any level that you find possible. So we hope that this slogan gets used and out there: participation propels psychology.
All right, well, thank you so much, Dr. Swedish. And if anyone has questions, feel free to write questions in the chat, and we're going to take questions at the end of our, towards the end of our session today. But moving forward, I have the pleasure of introducing our second speaker, who is Dr. Andrew Champagne, who is the Director of Medical Education and the Associate Designated Institutional Official at McLaren Healthcare. He oversees 9 medical training programs and leads approximately 200 physician faculty and residents. He holds academic appointments as an assistant professor in psychiatry, family medicine, and internal medicine through Michigan State University College of Human Medicine. And in his various roles, Dr. Champagne has functioned in the capacity as clinician, educator, administrator, and scholarly leader. He's developed extensive subject matter expertise in the areas of behavioral integration, population health strategies, medical education, and quality improvement. And he serves as a board member and the chair of the Integrated Care Committee for the Michigan Psychological Association. In addition to his doctoral and fellowship training as a health psychologist, Dr. Champagne has completed advanced degree in healthcare management with MSU, Eli Broad College of Business, and also holds a certificate in healthcare management from Yale University. His interests mostly recently have focused on advocacy work on value proposition for integration and system-based business models for integrated care. So without further ado, Dr. Champagne, thank you so much for presenting today.
Thank you so much, Rochelle. And I know that intro was a mouthful. I got to trim that down.
No, it was great.
Thanks for bearing with me. So diving in, let me share my screen real quick. My focus is going to be on talking about growing behavioral advocacy, specifically across the healthcare continuum. And this is not kind of a singular method, but just kind of the method that I've taken and kind of conceptualized to really kind of advance the advocacy mission. So I really have 3 components to this. Part 1 is looking at the macro view, so framing advocacy and talking about various spheres of influence. Part 2 will look at kind of a meso approach, so value creation at scale and developing competitive advantage. And then part 3 is looking at the micro view, so some of the tactics that we use to really kind of advance advocacy specific to health systems and third-party payers. So starting with the macro view, the 30,000-foot perspective, just frame setting, advocacy really is public support for or recommendation of a particular cause or policy. I think I'm preaching to the choir with this. As psychologists, we see advocacy in various shapes and forms. As I've kind of ascended through the ranks, I've got to appreciate various types of advocacy through the spheres of influence that I hold, and I see those spheres of influence being the tools in my toolbox. And I'll talk, about those in various capacities as I dig into kind of the more global strategy and approach to advancing integration in behavioral health systems. But my spheres of influence, my toolbox includes what Rochelle had kind of talked about. Introducing the next generation of physicians and behavioral health specialists through the medical system and medical education training, serving as a chief psychologist for fellowship training of specialty psychology and really advancing integrated primary care. At a systems and administrative level, serving as a service line steering committee member, and then at the SPTA level, being the ICC chair and board member. And I rely on each one of those spheres of influence to really kind of impact and advance some of the strategies in other spheres by combining efforts and really kind of pushing the strategy based on what we're working on, in each one of those spheres. So advancing this conversation a little bit more, behavioral health integration follows any industry life cycle. And really, we're kind of in the growth phase. I think our counterparts in medicine have been a little bit more mature and advanced. They've existed in the space longer. And what you see with maturation is really mergers and acquisition and consolidation of efforts. But for the behavioral health sphere, we're still kind of growing new ideas, new models, new approaches and strategies to how we do the work that we do and provide the services that we render to our patients and communities. Some of that is buttressed with new and kind of evolving understandings of what's important in the healthcare approach. I borrowed this from the Robert Wood Johnson Foundation, and it really outlines that policies, health factors, and health outcomes, that a huge contribution of this really kind of falls into integrative efforts. 30% are related to health behaviors, 20% is clinical care, and a lion's share of it is social and economic factors, which we can kind of bake into the DNA of our care models and really speak to from our unique positions as psychologists. Simultaneously, the Institute of Healthcare Improvement has put out a position piece saying that rank ordered opportunities to remove waste in the U.S. healthcare system based on estimated cost. Behavioral health is a huge opportunity that we can dig into, with almost $40 billion on the table that we can directly impact by kind of shaping and evolving our care strategies. And then lastly, kind of where the rubber starts to meet the road, we see some of the downstream cost impacts from what we can do as psychologists and disrupting by swimming upstream some of the healthcare delivery pathways. Here is a top principal diagnosis with the highest 7-day and 30-day readmission rates. And a lot of integration looks to target these downstream consequences of an inefficient system by swimming upstream a bit more and being a bit more proactive. So that really kind of sets the stage. Advancing the stage a little bit more in thinking through advocacy, I think we also have to think about value creation. And as psychologists, I don't think we're oftentimes trained to think in the terms of value creation. Once we get out and start to practice independently, or once we join larger systems and have a mission to direct ourselves towards, then it becomes a bit more clear how important value creation is. But we can develop value creation on a broad range of a continuum, whether that's direct revenue capture through some of the efforts that Aaron had mentioned about, through directly CPT codes, RVUs, and revenue generation, whether that's value-based or quality initiatives, working with third-party payers to think about value-based reimbursement strategies or bundled care opportunities, or whether that's cost replacement, thinking about downstream cost control by putting in more efficient systems of providers and service interventions. My business mind, when I did my business training, identified two opportunities to create what is called competitive advantage. And I think this connects to advocacy as well, because the more competitive you are, the more power that you have, the more effective you're going to be for advocating for your mission or whatever those values are that you're trying to advance. So in psychology, I think we're one of the unique spaces that takes both sides of competitive advantage. We can lower prices of cost of healthcare, which are exorbitant within a multi-payer system in the United States. And simultaneously, we can create unique differentiation through our advantage of targeting populations through population health strategies and improving the emotional behavioral focus of our patients. So packaging all of that, one of my missions as a healthcare administrator and educator has been to champion the idea of further integration to my health system. McLaren Healthcare is a $6 billion, 14 hospital enterprise. We own a health plan, and we really want to think about how we've infused behavioral health into the various facets of what we do. And as a psychologist, I've had a unique privilege and opportunity to make a compelling case to my counterparts and senior executives of why this is important. So the first step was really kind of sketching out a demand, and this follows any kind of business strategy or business plan. Pre-pandemic, we started this discussion, and through various thought leaders, you'll see here, I have the National Alliance of Mental Illness, I have McKinsey, and I have Harvard Business Review. We pulled in data, and we pulled in kind of the thought leadership of each one of those organizations to say, hey, in the future, there's going to be a really big opportunity on the table to kind of right-size care. So some of the opportunities that we spoke to directly were the opportunity of 1 in 5 adults experiencing mental illness pre-pandemic. 1 out of 8 ED visits being related to substance use or mental health issues. The idea that we have a huge projected demand post-pandemic, which I'll argue we're not even close to a post-pandemic reset of $100 to $140 billion of demand in behavioral health services. We're seeing that through private firms like Teladoc and hyper-competitive opportunities now. And then in Harvard Business Review, identifying that the majority of our counties in the US don't have quality access to a psychiatrist or psychologist. Moving that forward, I looked at our Michigan markets and said, this is the landscape of unmet needs. So the Michigan Health Endowment and the Altram consulting firm pre-pandemic did a study in Michigan to say, this is kind of the pie of care that's being rendered to our state. 62% of patients receive some form of care, but we have 666,000 individuals, again, pre-pandemic, that or 38% of our population that need care that aren't receiving care. So we're leaving a ton of opportunity on the table. My mission then was to go forward and continue to segment, target, and position some of our efforts to look at, bringing this advocacy strategy. How do we reach populations and individuals that have been marginalized or don't receive care, and how do we do that in unique and innovative ways? That goes to kind of part 3, the tactics, and I can speak more to this in some of the Q&A. I'm going to go pretty fast because I know I'm winding down on time, but as a health system, we had an array of services that was kind of a patchwork. Many organizations, I think, behavioral health has been something that has not received the same attention or resources as some of our medical colleagues. So our patchwork exists in kind of a less cogent, a less kind of streamlined approach to healthcare. And what we wanted to do is create a system-wide service line for advancing that. So my proposition and the advocacy that we did was focusing on creating a behavioral health service array, breaking it down by various forms of capabilities from remote to in-person to higher acuity, and then showing how health psychologists and behavioral integration could impact each one of those areas. I would say the most compelling argument that we had was really within integrated primary care, and I borrowed some of this from the APA. APA has identified just 6 factors contribute to over a third of all healthcare costs: tobacco use, poor diet, substance use, high BMI, high systolic blood pressure, and high resting glucose. So the panacea, or the opportunity that we saw there, was creating a model or perfecting our model of integration through PCBH, which we really kind of optimized in a contained capacity, and then started to scale this model across the various sites within our enterprise. And this was the foothold that we had for advocacy and integration. integrated primary care, and most of these integration strategies not only target the traditional fee-for-service approaches, but they start to tackle some of the bundled or shared saving models. And when we started to meet with our health plan, we thought about building in capitated and building in parity models for some of the services that we've provided, which we've achieved some pretty significant success, which I'm happy to talk about later on in the discussion. Most of this took a change management or change building kind of philosophy to get it over the line. So for us, we utilized the Cotter's model, the 8-step model of generating a vision, communicating that vision, empowering action, capitalizing on short-term wins to grow longer-term wins, and then systemizing that. So across our systems, really kind of replicating the success. And what this allowed us and continues to allow us is new opportunities in the Advantage life cycle, where we've kind of launched new initiatives, exploited that advantage, and then kind of counter-responded to evolution of our peers within our markets. What we're working on right now is kind of a more robust strategy of a centralized intake model that is start to finish care, and that integrates all of our care opportunities into one source. This is kind of similar to leveraging, the technologies that Erin had talked about in her presentation. We're using AI and teletherapeutic systems to start to manage our patients and direct them to the appropriate service needs, and from there rendering the appropriate level of care based on the severity of those patients, and really starting to demonstrate some downstream cost control. I'm going to stop there and say that there's a much bigger discussion that we can have about advocacy. We're really at only the tip of the iceberg. So I welcome questions and comments in the follow-up in the Q&A session. I'll stop sharing.
Thank you so much, Dr. Champagne. Definitely a lot of information to process, so I'm glad we'll have some time later to discuss. So I'm going to also introduce our next speaker, which I'm happy to have her here with us, Dr. Jan Mooney, who is a pediatric psychology postdoctoral resident in the Aflac Cancer and Blood Disorder Center at Emory University and Children's Healthcare of Atlanta in Atlanta, Georgia. And she is a recent graduate of the Health Psychology PhD program at the University of North Carolina in Charlotte, and completed her predoctoral internship in health psychology at Henry Ford Health. Broadly, she's interested in how complex body experiences such as pain might be influenced by systems and structures. And a primary avenue of her work includes understanding how legislative and policy systems shape individual and community health, as well as how to enact systems-level change through health policy research and advocacy. So very happy to have her here to share on her perspectives for advocacy work. Thank you.
Thanks so much, Dr. Hayes. I appreciate that. Yeah, thank you all so much. I appreciate you being here to hear our perspectives today, and look forward to hearing everyone's perspective during the Q&A. So as Dr. Hayes mentioned, I'm a trainee myself right now. So this is really for all the trainees and students in the room, and for those of us who just feel like we haven't quite gotten into this work yet. This is really more meant to be an encouragement of you all in your perspectives. If you're not involved in policy and advocacy efforts, that you're a really important piece of this. So what I really want to do today is to make a case for student and trainee involvement in policy and advocacy efforts. I think there are no financial disclosures, but partly as a consequence of being a student or trainee, I'm sure I don't really have to say this or emphasize it, but I don't have any conflicts of interest or financial disclosures to make. But what I want you to consider here is that students and trainees have a really unique skill set. They bring some critical expertise to the table in policy and advocacy efforts, and it's important for us all to be at that table. And so if you are a student or a trainee or someone who's not involved in this work right now, I want to challenge you in the sense that you are important, you belong at the table, and we need your perspective there. And as you're getting early on involved in some of this work, it can really set the stage for your long-term engagement and the contribution of your experience to this important work. I think there are a couple of main barriers that come up when we think about students or trainees being involved in some of this work, which I've experienced myself. So this is anecdotal, and I'm open to hearing others' perspectives during the Q&A. I think they fall under 4 main categories. Some barriers can come from the motivation, like why should I engage in this work? What's the point of it? Could come from knowledge, being concerned about, how would I even go about this work, or do I know what I need to know in order to do this? And then also, even if I do have this knowledge that I think is important to this work, what do I do with that knowledge? Where do I take it? What direction should it go? And I think a big one here at the bottom that we'll cover as well is having the confidence to undertake this work. Is this something that I'm capable of doing? Should I be the one doing it? Am I really part of this? So my hope is to take a little bit of time to address each one of these barriers and help you think about them in a little bit of a different way, to hopefully to encourage you in this work. So when I'm thinking about motivation, what I'm thinking about is just having maybe being sort of uncertain. I don't know if this is something that I want to do, or why is it important to me? What does it have to do with the work that I do? So I think whether you're in the research or clinical or a teaching space, I really want you to think about some of the aspects of the healthcare system that you encounter in your work. Perhaps it's in teaching about the healthcare system. It could be in research or questions that you're asking. It could even be with the folks that you work with. I want you to consider which are the issues that make it most difficult to offer the care that you want to offer, to study the issues that matter to you and the folks that you serve the most. Are there things that are getting in the way in terms of billing, or there services you're not able to provide because of the way the structure is? And what would it be like if that structure was different? If things were different, if the process was different, how would it impact your work and the health outcomes of the folks that you work with, or the educational outcomes of the folks that you train? So really what I hope is for us to think about advocacy as really upstream policy change. So I think much like Dr. Swedish and Dr. Champagne emphasized just now, this idea is that this is something that is a little bit up the range from where you're looking right now. We might be in a lake and there might be a river that feeds into the lake. And I think for us as students and trainees, this is really more not necessarily about swimming upstream perhaps quite yet, but rather just looking upstream. What does this look like? How can we get a better sense of this problem and how it has come to be? These might be the causes of recurrent issues that you're seeing in your patients, your clients, your research, or that you're educating about. Where do they come from? And so that sounds like a big ask. And so thinking about some of the knowledge that it might take to try to answer some of these questions, I think we just targeted the why of this and the motivation. So you're already a little bit aware at this point of why this issue matters. Why is it so important, and how does it affect the work that you do? I think that we've all, as students and trainees or folks that are maybe less experienced in this area, if you want to break into this area, you've already done some of this. And whether it was in graduate school or when you're writing academic papers, you know how to consult the literature, you know where the problems are, and you know how to use the literature in order to help you know what are risk factors, barriers, contributors to some of the issues that you're seeing. You already know some of that. And if you don't know yet, or this is a new area of research for you, you definitely have the skills in order to be able to gain that knowledge. And then I think where we're starting to extend here is, what are the rules right now? How can you get a better sense of what the current policy or legislative piece is? I think Dr. Swedish shared with us some of the acts that are in play right now. There are certainly acts that have been passed in the past, or what sort of the legislative landscape is right now that you can get either from reading on, if maybe you have a senator or representative that you think is really advancing an agenda that you think is important. They might have acts that they plan to bring in front of Congress, or things that they've supported in the past that they might think are important. So that might even be a way for you to get some of that knowledge. And so this is really a place where you can start to extend your skills to research current policy. I've also provided some resources at the end here that I hope will get you started in some areas where you can do some of this research, but really this is the same process applied in a different content area. You already know how to do research. We're just thinking about doing it in the legislative or policy space. And then ultimately, we're thinking about who owns this change. So ultimately, as I'm trying to figure out what changes need to occur, what needs to happen in order to improve this situation, who would be doing that? Would this be something that happens at the legislative level? Is this something that I need to go to my organization about, that their policy needs to change? Or is this perhaps even farther out at the federal government level? So starting to ask questions, talk to folks around you, and figure out who are the key stakeholders in this situation. And I think as you're starting to get a sense of who the stakeholders are, or maybe even about what this problem is and where it comes from, you might find yourself thinking about, okay, what do I do with this? Or where do I go with this information? I have it now, what do I do with it? So I think there are two main directions that we can take, especially as folks who might be still gaining experience, early career trainees or students. We might find that we can approach supportive faculty or supervisors. These may be more experienced folks who have experience in this specific area that we're interested in that can help us advance our ideas. So for me, some of this is around folks with sickle cell disease and lifespan care for them as they're transitioning into adulthood, and how do we keep and retain them in care and offer them the services that are important to them. I'm lucky to have an advisor right now who specializes in work with folks with sickle cell and the concerns that are important and unique to that population. So I'm able to consult her for help. If I happen to have an advisor who wasn't as experienced in the advocacy and health policy space, she might be able to connect me with others that she knows of that are interested in this area. Other options include joining an interest group. So I'm lucky to be the student liaison to the Health Advocacy and Policy Committee. So that means that as a student, I'm able to learn from experts in the field, like some of those that we just heard from. There are other policy and advocacy interest groups and other professional organizations like the Society of Behavioral Medicine, other divisions of the American Psychological Association, as well as policy-focused organizations like Research to Policy that are really open to student and trainee involvement and can help you get organized in this work. And I think ultimately here, one of the biggest things, especially for me, that continues to be a challenge is having the confidence to undertake some of this work. And I really want to say to you all that you can do this. You have the skills to do it. There you have clinical and research experience that helps you to identify areas that are of great need. The frustrations and problems that you're running into on a day-to-day basis that make it hard for you to do the research that you want to do, that bring about the problems that you're researching, or that plague the folks that you work with on a daily basis are important and deserve to be heard, and you have the knowledge about them that is really needed in order to push these issues forward. The skills that you gained in graduate school or in your training really help you to understand the current policy landscape. They're the same skills that you would use in order to understand what policies are in place and how could they change and what potential impacts might occur. And then ultimately, as someone who's been through graduate school, as someone who's done projects and milestones and papers, you have what I like to call educational stamina. So you have the patience to see something through that takes a number of years, that goes through ups and downs, and that it feels like it's stalled at times. And often the policy and legislative process can feel like that as well. So what could this look like? If you were to do some of this work, what could come out of it? I think this can occur in response to an upcoming vote. So perhaps a senator or representative is getting elected. Again, they're talking about policies and legislative change that are important to them. And you want to support that by voting in favor of them, by asking them to do something. Could be something that's an ongoing priority for you, something that you're always talking to folks about, giving elevator pitches or just speaking about at a conference or when you're talking to others you're networking with, just to get a sense of who else is interested in this area that can take the issues forward with you. This might involve completing a form or sending an email. So as Dr. Swedish talked about, EPA Services Incorporated, which is sort of separate from the psychological organization itself, is able to send out these action alerts, and folks are able to participate in them. You might fill out a form with some details that are relevant to you as a student or trainee. You might be surprised to know that legislators, as well as the federal government, are interested in your perspective and that it's important to them, especially when you're talking about your local area where you're a constituent of a legislator. So you might be making a call, talking to folks directly, or part of a larger organizational effort. You could work with a group to prepare a summary of research. So we often find white papers published on websites or policy position papers published in journals or as part of an organization. Those can be really helpful. They might even go directly to legislators. So you could have something that's more broadly released online in a social media post or as an opinion editorial, or this might be more of a limited release, having conversations with a specific legislator that might ask you, hey, how does this affect my constituents? I know they're really interested in XYZ area. Can you help me learn more about that? So you might be able to develop a relationship with a specific person. Or you might just be kind of sending it out there and hoping that folks are able to gain awareness, that you can collect more folks to join you in your efforts. So I think ultimately what this encouragement is about is to understand that there are lots of different outcomes that can happen, and lots of different ways that you can be involved in them. But really that, having that motivation, that you have that knowledge and gain extra knowledge, and that you're able to take it in a direction, and that that your perspective is important is really what I hope to communicate to you today. And so I've included some resources here that you're welcome to scan the QR code or visit that short link below. And really, for me, this is a work in progress for myself. And so what I hope to encourage is for you to join me in this work, to provide me some feedback, maybe during the Q&A, about how we as a group can help make sure that students and trainees and those that might not have gotten into this work yet can be encouraged in contributing the really important knowledge that they do have. And thanks so much for your time.
Thank you so very much, Jen. Thank you for all the work that you do for our council, and encouraging your junior colleagues and everybody else to join in these efforts. Our next speaker is Dr. Mena Hurtado from Yale University. He's interventional cardiologist, associate professor in medicine, and he's the director of the Vascular Medicine Service Lab at Yale New Haven Health Hospital. And as we announced in the beginning, this is a multi-stakeholder perspective, and integrating care and serving specialty populations cannot happen without the support and advocacy from our physician colleagues. So Dr. Mena will be representing that perspective, and his presentation will be specifically about cardiovascular populations. So welcome to our webinar, Dr. Mena. The floor is yours.
Right. Thank you, Kim. Thank you, everybody, for joining. So the topic is interesting because in my journal, or in my journey as an interventional cardiologist, the focus has never been about the issue of a multidisciplinary approach as it relates to mental health issues, so to speak. But as I continue developing my career and treating a variety of patients with chronic conditions, one quickly realized that in order to be successful and effective at managing all these patients, you really do need to take into account all the different dimensions of what the patient brings into the table. I am going to go through peripheral vascular disease and particularly critical limb ischemia. And it's an interesting topic for a variety of reasons. One, it's highly prevalent. Two, the consequences are significant in terms of morbid mortality. But the most important part that is relevant for this conversation is the fact that the issue of mental health in patients with vascular disease has been completely overlooked and nobody paid attention. Up until recently, the major focus was always about revascularizing a specific limb and or healing a specific wound. But the wound that persisted open was the one of the mental health that these patients come with. So let me walk you through my presentation briefly. These are my disclosures. There are some, they are not relevant actually for this conversation, but they're listed in this slide, so you have it as a reference. As you may or not know, atherosclerosis is a systemic disease, and the most common form of presentation is coronary artery disease in the way of a heart attack, heart failure, or a stroke. But in this particular case, I am going to focus in the lower extremities. Typically, the patients will present in one of several fashions. As you will see in the slides, peripheral vascular disease, despite of optimal medical therapy, which is actually not that well prescribed, the rates are somewhere in the 40–50% range, work that has been done in our outcomes lab. Despite of that, there is a significant problem in this population is the fact that they have high incidence of major adverse cardiovascular events as well as limb events. In fact, if you look at the specific group of patients with critical limb ischemia, the mortality at 6 months can be as high as 20%. And if you keep those patients or follow those patients, could be as high as 50% at 5 years. Incredibly expensive. And a lot of that expense is being done as an inpatient. On the right side of the graph, you can see somewhat of the spectrum of how these patients present. Many of them are asymptomatic. Some of them have symptoms that could be atypical, or they could be the typical claudication, or in the more severe case, critical limb ischemia, which is defined by the presence of rest pain and or tissue loss. We all know what the traditional risk factors are for this type of pathology, which include smoking, aging, obesity, sedentary habits, diabetes, and so forth, so on. But when we continue to dig deep into it, there is a very strong relationship between how these patients do and their association with mental health issues, that being chronic stress or affective disorders. I am not an expert on these topics by any means, but the work that I've done with my colleagues, including Dr. Smolderen, have allowed me to understand that there is a very strong connection that can be explained by very clear physiological and pathological pathways that at least in the vascular medicine field, often were ignored, and now we're shedding some light into it because it's important. There is increased adrenergic state, as you can see it on the right side of the screen. There is an association with insulin resistance, central obesity, hypertension, inflammation, platelet activation, endothelial dysfunction, and so forth, so on, as a consequence of mental health problems. So when someone presents with an acute ischemic leg, because they have, a clot that traveled there, the traditional view was, well, you give them some medications and it'll go away. But there is a cohort of patients that have these underlying mental health issues that are not being addressed and continue to be either a chronic player or they don't really get better. So it's a real problem. So what have we done to try to uncover this? We started looking at the association between different mental health pathologies and vascular disease. And that's what I'm going to walk you through, because it really did open my mind, or mind, to the issue. To that extent, Dr. Smolder and I recently published an American Heart Association statement about the association between mental health problems and peripheral vascular disease. Similar work was done and published in other major journals. And I think it's important, particularly for this audience, to realize that we're in desperate need for your guidance, help, and support managing these patients. The traditional approach was used to be, you have a blockage, I open the blockage, you're all set. Doesn't work for these people. So PAD, as I mentioned before, is a marker of generalized atherosclerosis, is on the rise in high income and low and middle income countries, particularly for both men and women. And it's a serious health problem. And you can see the graphs on the right that show the higher and increased prevalence of pre-PAD in different populations. So we started to look at things. One of them was this issue of depression. As you can imagine, peripheral vascular disease can be managed by exercise. But how often can a patient who is totally depressed with high levels of severe anxiety can actually do that? On this slide, you see some of the papers that have been done showing the prevalence of depression in patients who present with peripheral vascular disease. And you see that the numbers are not small. When you look, for instance, at the combination of hospital anxiety and depression, it can be as high as 30%. The numbers in terms of patients in this studies also is not particularly small. So this definitely captured our eye. We then said, okay, so how about the critical limb ischemia? What's happening with these patients? So we started looking at that, and we saw a few things. In the slide, you see men and women younger and older than 65 years old. You can see that there is an increase in the prevalence of this pathology in patients that are younger than 65. And this is from a paper that we published in actually was in the Journal of American College of Cardiology. And when we look into that, we also were able to identify that patients who presented with PAD, critical limb ischemia, and had comorbid anxiety and depression, the numbers are going up. So highly prevalent, affect young people, and coexisting depression and anxiety is highly prevalent. So what all those patients look like? Unfortunately, many of them are the patients that don't get the best care, which are usually those patients from marginal socioeconomic status. Hispanics, like myself, African Americans. Typically, most of them do not or have insurance issues. When it comes to women, the same thing for men. You see the median income, the prevalence of comorbidities in those that are young, right? And the most important part, both in men and women, as shown in the slide highlighted in yellow, is the high prevalence of these mental health disorders. We see depression, we see bipolar disorder, we see anxiety, we see stress-related disorders, alcohol abuse, drug abuse, particularly opiate abuse. So patients come with pain, which is the cardinal symptom in this pathology, and they are, I don't want to say mismanaged, but they are given opiates without any second thought or consideration in someone who is already depressed, who has an anxiety disorder, and that basically starts a spiral, a down effect that ultimately result in bad outcomes. The issue of the association of these pathologies and major amputation as it relates with patients that undergo revascularization. So whether we open the blockage or not, alone is not going to do it. If this patient has these unaddressed mental health issues, their outcomes are going to be bad. The same applies for length of stay as well as the cost of these patients when they undergo these procedures and there is comorbid depression as a diagnosis during that admission. They do worse. So if you don't think about it, if you don't address it, if you don't screen for it, you are missing a very key element in their patient's clinical presentation that ultimately will affect outcomes. As you can see here, mortality and major adverse limbs events, meaning amputation, are heavily impacted by the presence of depression, just to use one of the different pathologies as an example. So ignoring this is basically you're doing half of your job. As an interventional cardiologist, that we pride ourselves of being fancy because we use all these fancy techniques and equipment and what have you, we're not doing a good job. We're doing a lousy job because the job of opening a blockage is just the tip of the iceberg. If you really want to make your patients better, and we have these conversations in many of the different societal meetings, including the American College of Cardiology, American Heart Association, the Society of Vascular Surgery. If you really want to do good for your patients, you got to include this dimension. So in conclusion, increasing demands and strains on patient populations and health system are going up. The traditional view of treating diseases in which opening a leg was enough doesn't work. We need to be able to include this other dimension in the management of our patients. And I think that entities like Medicare are listening to us. And we are moving towards an era where integrated behavioral healthcare models across the spectrum. And I could have talked about coronary artery disease, heart failure, stroke, you name it. But I decided because of time constraints to focus on vascular disease are the way of the future. Not doing it this way is not going to be good. The challenge is that for years and years, our specialties have neglected the importance that your specialty has in the management of our patients. Because of that, we live in silos. The challenge is how to bring enough awareness, understanding from both sides so that we can come together and develop strategies that are holistic in nature and can help to bridge the gap that exists in the management of these patients. With that, I finish, and thank you very much for your attention.
Thank you, Dr. Mena, for a great presentation, practice, collaboration, advocacy for the biopsychosocial model of care. I'm Valeria Martinez Caigi. I'm the Associate Chair of the Health and Advocacy and Policy Council. My pleasure next to introduce our keynote speaker, which is Dr. Daniel Bruns. He has been a practicing health psychologist for over 36 years and specializes in the psychological assessment and treatment of patients with chronic pain and injury. He is a fellow of the Society for Health Psychology, past chair of the American College of Occupational and Environmental Medicine Medical Treatment Guidelines. These guidelines have been adopted as legal regulations in California and New York and are also the national treatment guidelines for worker compensation. He is also the past chair of the Colorado Medical Treatment Guidelines and helped develop the state's medical treatment system for injured workers. He has been a contributor to over 20 other medical treatment guidelines, primarily for the treatment of chronic pain and injury. He served as a technical expert for the Centers of Medicare and Medicaid Services and served as a keynote speaker for a summit funded by the Substance Abuse and Mental Health Administration. This SAMHSA summit was convened to guide the development of the treatment systems for addressing chronic pain and opioid dependence. He's authored numerous research articles, book chapters, and standardized psychological tests pertaining to the assessment of patients with injuries or chronic pain. And he was the principal investigator in a 15-year longitudinal study of 29 million injured patients, which helped to establish the benefits of the biopsychosocial model. He is the recipient of multiple national awards for his work as a pain psychologist, and we're so excited to have him share his expertise with us today. Without further ado, Dr. Burns.
Thank you so much. Let me get my slides going here. Hopefully you can see those okay. First of all, let me just compliment the other presenters. It's been very interesting hearing about all the wonderful work you're all doing. And it's having been working in advocacy for a long time, it's exciting to see all the stuff that's happening. To start, I want to just point out that I have one disclosure, which is I'm the co-author of 3 standardized pain psychology tests published by Pearson. I want to talk about the process of advocating for change. And I want to focus more on the process as opposed to all the data, because there's so much of that. And I want to talk about just intuitively what it's like to be an advocate and strategies for being effective. I started out with my first advocacy presentation, I think 36 years ago. And sometimes I've felt like this when advocating. It's just like I was out there by myself. Sometimes when you advocate, you have a team of like-minded people, but sometimes not. And on many occasions, I've found myself just feeling that something needed to change, feeling that something was wrong. But I was just on my own with that. And, I work in a small clinic. I'm self-employed. It's a group practice with 5 other psychologists. But I'm not part of a medical center. I'm not part of a university. And so in many cases, I was on my own. And sometimes, whether you're in a university or not, you may be in a university, but not have any support and maybe have a good deal of opposition. Sometimes the path forward has felt like this. It's just like, wow, how am I going to get through this? And so I think as an advocate, you have to strategize about getting through difficulties. One of the things I found that was helpful is to remember that this is not all about me. And so when I was trying to find a way forward, just think, this is not about me. This is about some problem. And so over the course of time, initially I advocated about things for me, but as time went on, I started to see things differently, more like this. This is I love this picture. It's a spider web after a rain, and all these drops are on. And if you look up at it really close, it's like each drop was like a lens on the world. And I think a lot of times conflicts are like this, or systemic dysfunction. There's a web of interconnected perspectives, and they're all different. And you can't change one without changing the other. And so I learned that I shouldn't just focus on my own perspective, but rather to look at all these perspectives, because to change things, I needed to see the bigger picture. And also, when I made a suggestion, I needed to try to shed light not just on my problem, but to try to shed light on all the other interconnected problems. And if I could also shed light on other problems, others were more likely to support it. And so I started to think in that way. A lot of times, working by myself, I've thought, how can I affect the world? I'm one person in a small clinic in a small town. How can I have an impact? And looking back, I think it was a failure of imagination on my own part. I think we need to perceive ourselves as having a power to make a difference. And I've come to believe that ideas have power. And some ideas are so powerful they can take root even in adversarial circumstances. And so we need to find those ideas that are clear and powerful and that can take root, and ones that don't just address your problem, but that address the larger scope of interconnected problems. My first presentation was just about 36 years ago. And I've referred to that presentation sometimes as a presentation about pre-surgical geology. Now that sounds kind of bizarre, and I say it tongue in cheek, but it was actually about pre-surgical psychovalves. But in 1987, this term was like pre-surgical geology, is a complete non sequitur phrase that nobody had heard of it. It sounded bizarre or impossible. And so I needed to educate people about that. So in this first presentation, it was to a state of Colorado regulators. And so I made this presentation about integrated pain care and pre-surgical psychovalves. And after my presentation, it was quiet for a while. And then one state regulator, who was a nurse by training, said, "Now, let me get this straight. You're a psychologist, right?" "Yes." "And you're talking about evaluating people who have real medical problems. Is that correct?" "I guess you could say that, yes." "Isn't that unethical? Isn't that outside the scope of your profession?" And so the discussion came about, is like, well, is health psychology inherently unethical? Because psychologists obviously can't treat people with real medical problems. But I managed to persuade some of them. And in particular, one person had a powerful position in the state, was interested, and we continued discussing that. And 4 years later, he asked me if I would testify before a Colorado Senate subcommittee about, it was about healthcare reform, and to present these ideas about pre-surgical psychovalves and interdisciplinary care. So I did. Now, over the course of time, what I learned is it wasn't just my issues, that in Colorado, and in particular in the workers' compensation system, things were really dysfunctional. There was medical hyperinflation. The medical inflation rate averaged close to 50% a year. I mean, that's an astounding inflation rate. Insurance got so expensive, just the workers' compensation insurance, not regular healthcare insurance, just workers' compensation. In some industries, for every $1 of care, the insurance cost $1.20. So insurance was greater than payroll. Insurance companies responded with extreme utilization review, just deny care to control costs. And then so people would sue and care was denied because pain was psychogenic, but they wouldn't authorize psychological assessment or treatment. People would go to court, the judges would overthrow it, people would get surgery 2 years late, and then it wouldn't work. And it was incredibly dysfunctional, incredibly expensive, and had poor outcomes. So over the course of time, Colorado passed a healthcare reform act that was pretty revolutionary, and it mandated the development of guidelines. And I began serving on these panels around 1994. There was a rule, it was an interdisciplinary panel. The rule was one profession, one vote. first meeting, I was told by psychiatrists, psychologists could not vote. We were not qualified. And so right away, there were difficulties. And so I had to talk to the state regulators and say, you have this policy, one profession, one vote. I'm told I can't vote. You should either rescind the policy and say, we didn't mean that, or if you mean that, then I should be able to vote as a psychologist. And so I became the voting member as a psychologist. Later on, I wanted to serve as guideline chair and physician educator and in other similar capacities. I had to learn about this process of developing regulations. You know, I could say that, well, here are these 3 meta-analyses that say this or that, and they'd say, well, that's interesting, but that would have no effect because it wasn't a concrete suggestion. And so when I learned what was needed when writing regulations was to say, I have a concrete proposal. We go to Rule 17, Exhibit 9, look at page 163, second paragraph. I would suggest changing the wording to this. And now here's the scientific rationale. And now once there was a concrete suggestion that could be voted up or down, and over the course of years, sentence by sentence by sentence by sentence, we wrote about 3,000 pages of regulations which controlled the practice of healthcare. And here are 3 of the biopsychosocial laws we developed. We called them biopsychosocial laws because they were regulations that had served as not just medical treatment guidelines, but also as legal regulations enforceable in court. So about 3,000 pages of these. So these were our biopsychosocial laws, the system we developed. In those laws, Colorado recommended or required pre-surgical psychovals for about 10 different procedures. No other state did this. And one of the things we realized in the middle of it is like actually, it was something I noticed one day at a meeting that we had created a legislative natural experiment. Now that's an experiment where a legislature creates an experiment. It created a treatment model with these guidelines that were legally enforceable. No other state did it. That was treatment as usual. And I served as the principal investigator of what became a 15-year longitudinal study of 29 million patients. And over the course of the years, what we found was that in 1 year, this model, which was feared to inflate costs by adding psychology, saved $859 million in 1 year. It was better care for less money. And there's a copy of the paper, and there's a reference list at the end. And so this established that these biopsychosocial guidelines at a system level, implemented broadly within a state, could not only deliver best care, it could do so for less money. Over the course of years, at this time, about 40 guidelines now recommend or require pre-surgical psychovals and integrated pain care. I've served on 20-some guidelines, I think. And over the course of time, it's become common parlance that even though it was a non sequitur phrase to say pre-surgical psychoval 30 or 40 years ago, now it's commonly mandated. So how that happened? One time, a number of years ago, I was asked to consult with a payer. And so I flew out to their headquarters, and I met with their COO, their chief financial officer, and their chief medical officer. And so we were talking about this. And one of the things I've often found is that you can get lost in the data. There's so much data, some of it's so complicated. And especially for business people, they don't always understand the intricacies of complex research. And so I've tried to find ways of explaining people at an intuitive level. I'd have, for their science people, It have all the data and references and things spelled out, but I needed to make the case, in this case, to business people about why they should do this. And so one of the things I've done to have an impact is, in some cases, I developed cartoons to make the point. And so I'm going to share one of these with you. It's a cartoon, Harold and Dr. Cutter, and they're discussing surgery. So here's Harold and Dr. Cutter. And Dr. Cutter says, so the MRI shows a small herniation L4, L5. How do you feel? And Harold says, it's a little uncomfortable, but I'm okay. And so Dr. Cutter says, okay, if it gets worse, give me a call. We can do surgery. Now let's replay the conversation. Dr. Cutter says the same thing. So the MRI shows a small herniation at L4, L5. How do you feel? And now Harold says, PT doesn't help. The pain is killing me. I can't work. Either fix me or give me pain pills. And Dr. Cutter says, okay, well, let's review the surgical options. So how are surgical decisions made? When do you decide to do surgery? To what degree are surgical decisions based on examination and objective test results, or what patients say and how they behave? When surgery is performed, how do you know when surgery is successful? Well, it turns out that's pretty complicated. Most randomized controlled trials for pain, especially in orthopedics, the outcomes are behavioral. There are objective outcomes like successful fusion. That's objective, biological. The two bones have fused together. But other variables, pain, subjective, satisfaction with care, subjective, quality of life, subjective, functioning. They often use self-report, although a physical therapist can test it, and that's behavior. Reduced opioid use, behavior. Return to work, behavior. So for surgery, and surprisingly, most of the outcome variables are behavior and self-report. So this leads us to a paradigm shift. To the extent the decision to perform surgery is based on biological variables and the outcome is determined by biological criteria, surgery is a biological treatment. But to the extent that the decision to perform surgery is based on behavioral variables and the outcome is determined by behavioral criteria, surgery has entered into the behavioral world and it's a behavioral treatment. To the extent surgery is intervening in the behavioral realm, you're performing surgery to change verbal behavior. What do people say afterwards? I'm happy with my care. I'm satisfied. I don't need opioids. My pain level is low. These are all verbal behaviors. And importantly, the majority of surgeries in this country, orthopedic surgeries, are performed based on demand. My foot hurts, my knee hurts. It's when the patient requests it, when the patient complains. And that may determine the majority of orthopedic surgeries in this country. In the meeting with the payers, we talked about the economic analysis, and I presented the data I have. And so in 2014, a lumbar fusion cost $30,000, a multi-level cervical fusion, $120,000. And now those surgeries create significant burdens, have significant complications with infection and failure of fusion and so on. In contrast, behavioral treatments, 10 sessions of group CBT, $300. The lumbar fusion is 1,000 times more. Cervical fusion is 4,000 times more. What's extraordinary in a hospital, the cost of an H&B, 15-minute session is less than a Tylenol. Now that kind of blows me away. But in terms of what was mentioned previously, the transition to value-based care, when it comes to value-based care, what you get for your money, psychologists rule. I mean, in many cases with select patients, CBT works as well as a fusion. And if you think about, what treatment is more likely to change verbal behavior? So in many cases, it's not surprising that CBT does so well. So even though I still think we get shortchanged in terms of reimbursement, but what we do in value-based care models, our treatments rise to the top. And not surprisingly, the payer decided to adopt a biopsychosocial guideline. One of the things I've also done over the course of time was early on, we talked about doing pre-surgical psychovals, but early on there were no tests, psychological tests designed for pain patients. All psychological tests were designed for people with psychiatric disorders, not medical disorders. And so we had to advocate for psychological tests being developed. One of the things that I struggled with, was early on, the very first presentation. It's like, how can a psychologist do this? And so what was the theory behind this? What was the theory of how psychological variables, psychosocial variables, impacted outcome? And so we explored different models. We thought item response theory didn't work. What we ended up deciding on was something called field theory as the best way to explain. Now, one intuitive way of understanding field theory is it's kind of a chaotic theory model. It's like, how does a path of a comet go through the solar system? You think about it orbiting the sun, but along the way, it may go past Jupiter or Saturn or a different planet, and that can alter its course. And so even though you predict a course, it can be a chaotic equation. Other variables along the way can totally change the trajectory. And so it is with medical treatment. You think about the normal path, but along the way, okay, there's a surgical infection. Or the payer says, we won't authorize that care. And so along the way, there's a monkey wrench that totally alters the direction of care. And so we proposed a model that looked like this. It was based on a field theory model, but there are psychosocial risk factors that may give rise to the onset of a condition. Then a condition begins, and there's a psychosocial or reaction to it. There may be pre-existing psychological factors that can also change the trajectory. There can be social factors that change the trajectory. The person tries to access care, and sometimes they're successful, but sometimes there are disparities of care that block that. And so this governs the trajectory of recovery. And all these factors together, which you can put into regression equations, can predict the outcome, knowing that sometimes one monkey wrench along the way, one variable can totally change the trajectory of a person's recovery. I've also served as a consultant for the CMS. CMS covers 100 million lives, and I served as a technical expert for a while as part of a $43 million study that could influence up to $20 billion of medical reimbursements annually. I was one of 8 or 9 technical experts, and I had a vote for psychology. And we addressed complicated questions pertaining to substance abuse and what are called beneficiaries with complex needs. The very first session, we received, I think, 270 pages of charts and abstracts and data CMS has an incredible amount of data on 100 million patients, every session, every diagnosis, every treatment, gigantic amounts of data that are just stored chaotically. And so we were trying to make sense of things. And we're given 270 pages of data and asked, here are 14 proposals. How would you rank order them in terms of importance and also important in terms of doability? Is it possible to do these things in the field? And why? And we were successful in making a number of changes. One of the more concrete ones was adopting a national policy to screen for anxiety. Now, sometimes the results of advocacy seem modest, like screening for anxiety, but when you apply that to 100 million lives, small changes like that can have major implications. I've also been involved with advocating for changes with what was called the Focus on Function Symposium, which was done with the CDC and a number of medical societies. This began with just a reflection between myself and one of my collaborators, Catherine Miller, a physician, and thinking about the 90s, where there was the focus on pain and the 0 to 10 pain scale being used all the time. But that led to, okay, you have pain, we'll treat you with opioids. And that contributed to the opioid crisis. And looking back, we thought, well, we shouldn't have been asking about what's your pain level. Better, how are you doing? How are you functioning? And so if we had focused on function, that may have been a better way to deliver care. And so we thought, how do we change medical practice? And one of the ways to do that would be to change medical software. Could we change all medical software to not just ask, what's your pain level, but some way of asking questions like, how are you doing? Because hopefully our care will help people do better. And so we persuade APA and ACOM to support an initiative. And this was later sponsored by the CDC. NIOSH is a part of the CDC, which is focused on reducing disability and improving function. And these were the attendees of the Focus on Function Symposium. And we published a joint statement in 2020. Now, this is still in process, and we're still trying to find ways of implementing this. It's a long-term project, even to make a small change, like adding one question to all healthcare records. Recently, there was a meeting where it was attended by physicians, attorneys, judges, because we're talking about changing regulations in places. And I pointed out there were some physicians who really liked one standard, but I point out the weakness of it scientifically and asked the judges, now, if this was pointed out in a trial where it was said, this standard has these weaknesses, would you accept this as evidence? They say, no, we'd exclude this as evidence based on the weakness. And so sometimes, in this case, I appealed to the judges to say, no, this wouldn't work. And then I said, I thought you might say that. Here's an alternative proposal that I think would solve those problems. Recently, I've been advocating with SAMHSA and something called the Opioid Response Network. SAMHSA is Substance Abuse and Mental Health Services Administration, and they were tasked with developing the Opioid Response Network to reduce opioid mortality. What we found, though, is that SAMHSA didn't include pain psychology because pain psychology was not mental health. And so Jennifer Kelly, Ravi Prasad, and I had developed APA's first pain curriculum. And so we're talking now about SAMHSA, APA, and the Opioid Response Network co-branding pain curriculum as part of this process of addressing opioid mortality. So we're trying to get APA and SAMHSA and the ORN to all collaborate in this process of addressing this national emergency. One of the things that I also often do in terms of advocating for patients. Sometimes it's big things, like dealing with national policy. Sometimes I advocate one person at a time for patients in litigation. A lot of psychologists don't like getting involved in litigation, but between 1 and 2,000 times in my life, I've had to offer opinions that were used in court cases to help patients access care. And not something I enjoy doing. I'm not a forensic psychologist, but as a treating psychologist, sometimes I have to advocate for my patients to get the care that they need. Sometimes within APA, we advocate. We talk with the practice directorate and others just to try to help shape APA policy. So advocacy can take many forms, from advocating for one patient to get the care they need, or advocating with the state, advocating with medical guidelines, advocating with federal policy. There's so many ways that advocacy can occur. And all of them are important. And I'm delighted to hear about all the things being done. Here are a few references of some of the articles I've mentioned. And I'll look forward to taking your questions, I guess, at the end. Are we doing that now? But thank you.
Yes, thank you so much. That was so enlightening, and we're so grateful for all the work you've done on behalf of our field for many decades. And we would like to invite questions. You can post them in the chat. You can raise your hand. We can call on you, but we want to invite to have a really good discussion on such important advocacy work.
Thank you, Dr. Bruns. That was really an amazing presentation, as thinking about some of the obstacles that we're still navigating to put integrated care into place in academic health institutions. What I didn't perhaps hear you talk about is the issue of power dynamics, and how it always feels like we need to justify the care for this and do our homework, which is important, and do the outcomes work and run the numbers. But I can't seem to ignore the fact that, yeah, it is also like, who holds the power, and how can you be at the table sort of with an equal power dynamic? And that's the thing that I'm still struggling with. So any wise words on that?
Well, yeah, some things don't change very fast. And like some of my very first experiences, like, what are you even doing here proposing this with the state? And then when the state convened something, it said one profession, one vote, well, except for psychology, of course, and having to advocate for that when we've mended fences with psychiatry, but early on, we were strongly opposed by psychiatry as not being qualified even to be at the table. And so I think one of the things that's been helpful is, Kim, your research about, in cardiology and all this research in other areas showing that, this whole siloed model isn't right. And that this, what was that one slide that said behavioral factors were 30% of outcome, I think? And like, well, that speaks. And so now sometimes, though, there is this power dynamic, but at the same time, now I've felt like those early slides, like, wow, I'm out here on my own, and like, how can I have a voice? But ideas have power, and this research has power, and sometimes you have to think about the audience and with the information you have, who that persuades. Now, like with in our study, on one hand, you can say, well, it saved the payers $859 million in 1 year. Now, to a hospital CEO, it's like, oh, this is horrific. We're losing that much revenue because we aren't doing that many surgeries. And so you have to think about your audience. And sometimes you have unexpected allies. And so when you have, like in this model about, in our case, pre-surgical evaluations, that some people, aren't going to say they're better. They're just, so negatively focused. They just aren't good candidates. And so payers became our ally. And so payers would say, okay, that you aren't practicing well. We will incentivize you. In my work with CMS, they were talking about value-based care and switching $20 billion worth of reimbursement based on, did people follow these guidelines or not? And I think payers, if people don't listen to the data, maybe payers will, and then the CEOs listen, even if they wouldn't listen to a psychologist, unfortunately. So what I found is there's some physicians who aren't open to that kind of collaboration, but others are. And so you find those people who are collaborators. And I know I've at times I've been an educator for surgical societies, and some surgeons are very open to it, and some surgeons are not. And so you develop coalitions with the other medical professionals, and also you search for strategies. You have your own opinion, but what are their problems? And that whole idea of the web of perspectives, if you can find a solution that helps you with your problem and helps them with one of theirs too, that takes a lot of thought. But if you can do that, then they will support it because part of it works for them too. So it is a long process.
Yeah, it is a long process, and I agree with the allyship and strategizing. But by default, developing some successful strategies, meaning some power, you're taking that away from people who are clinging on to that power, and that's the threatening part.
Yeah.
And it's not about the rational argument, because all those numbers make sense. It's about the emotion of what you take away from leaders, people who are holding 100% of the power. And that's very, at the core, emotional.
Yeah, and I have all this data, but sometimes I've used things like cartoons to get beyond that. Here's an example. There was a hospital system when I was talking about doing evaluations, knowing that this would reduce the number of procedures, and what finally persuaded the person, who was an interventional pain physician, was talking about implanting stimulators and who to implant, and screening for like personality disorders, that people with characterological disturbances aren't good risk. And he went, oh, I didn't think about that. He said, my first wife was diagnosed with borderline personality disorder. And that was such a painful experience. And, he said, when I implant somebody, I'm married to him. And it's like, that's the last thing I want to get into. And so it turned out that was the the compelling argument for him. And it was a gut level. Yeah, I've had just that experience of being stuck with a patient I've implanted, and I didn't know what to do with them, and they kept coming back. And so sometimes it's data that persuades people, but sometimes it's something altogether different that persuades somebody about why they should do that. Another physician said, never underestimate the importance of alleviating the pressure from all the problem patients that a physician has. And so knowing your audience, knowing their perspective in the whole web of perspectives, what motivates them, listening to what their problems are, and try to craft an argument that not just advocates for your position, but also addresses their concerns. And if you do that, then they can support it too.
Thank you for sharing your insights and your personal journey with us. Any other questions from the audience or for the other speakers?
I just want to say, Jan, I also am a postdoctoral fellow, and I really appreciated everything you spoke about, because I very much resonated very much with me. I was wondering, I know I'm kind of new to a lot of these regulations and kind of dipping my feet in this area. I was wondering if you know anything about the ADAPT regulation and what's going on there in terms of advancing like trainees work.
Yeah, I think that's a great question. I'm going to punt that one to Dr. Swedish. I think she'll do a lot better job of talking about that.
Okay, thanks.
Sure. So that was one of the federal legislations that I spoke about briefly. And really it is we know that's a huge problem, that trainees and postdoctoral fellows cannot get reimbursed right now. And so it's been a huge advocacy point through APA to get something through. And right now that the ADAPT Act is out there, and it's to develop sort of a Medicare modifier so that then under the supervision of a licensed psychologist, doctoral interns and trainees would be able to bill. So we're just sort of, we're in that waiting period to kind of see what happens. But it's definitely a huge point that we have been working on a lot, in different ways, but then finally this act has been introduced. So
I have a question here. Under the terms of that, how would it work out exactly? Would it be that a psychologist co-signs or has to see the patient sometimes? Is it like a PA and a physician, or how would that work exactly?
So it's set up so that it would be this modifier that ideally the psychologist would not have to directly see the patient, so that it's just under the supervision, and that the psychologist would be there to sign off as a supervisor, but not sort of have to see the patient directly, that the trainee would see the patient.
Okay.
Thanks for and it looks like Jan just posted more info about it.
Okay.
I was just going to say, Lauren, relative to your question, I appreciate the appreciation. I'm glad there are folks out there who are hearing some of this encouragement and find it helpful. I did want to say that just like this link, you can go on congress.gov and you can search any of those bill names, so you can see where acts are in terms of being introduced, whether they're being talked about, who supports them, and those kinds of things, so that at least you can get a sense of where this is in the legislative process, because oftentimes things will need to be heard multiple times, sent to committee and things like that before they can actually get anywhere, which can be frustrating, but it's also helpful to know something about where it's at.
Yeah, sure. No, I appreciate that. Thank you.
Yeah, I think that could be really helpful, just, excuse me, to expand the workforce. I'm sorry, go ahead.
No. I was just going to say there's also links on my slide to each of those legislation. So I feel like folks are going to get the slides, or I don't know how that works, but if not, I can provide the link separately.
If I could just make a comment, and maybe Barbara Keaton can follow up on this comment. One of the things we're really about advocacy. Advocacy is in the society's mission statement, right? But what we're also struck with is how we have to be careful about some of our messages that we convey. And as a tax exempt organization, kind of the narrow window that we can make statements about legislation, about candidates, things like that. And I know we're talking with APA Legal right now, just trying to sort that out. But I'm just curious in this group in terms of how people have sort of threaded that needle and being able to say those things you care about, but things that might be considered partisan, supporting one candidate or another, or one party than another. And obviously we're free in our individual lives to make all those statements we want. And yet sometimes in our professional roles, representing either our healthcare organization we're part of, or a nonprofit like this society, we're somewhat restricted on that, on what we say. And so it's my question maybe to Aaron, but everybody else, how do we be true to ourselves, yet know we have some of these restrictions on how we can say or not say things?
I have a thought, or I don't know the answer, but I think for us as a council, we try to be very agnostic about political issues. Of course, we want to know what's going on, what initiatives are being prepared, but reformulating this as a human rights issue, I think exceeds or transcends the political discourse. And that's, I think, where the true advocacy lies. This is a human right to be treated and to be seen as a whole person. So to emphasize that point, I think everybody can agree on that. So that is transcending different parties and viewpoints, and that's what I'm hoping, or I'm committed to push forward.
I'll just add to that most of the societies, almost all of the societies' advocacy efforts are coordinated through APA for two reasons. One, because the society is a constituent part of APA on the 501c3 scientific educational side. And by combining our efforts, we know that we're aligned in the APA statements and the APA policies. We also have the advantage of our voices being amplified and reaching into areas that as a division or as individuals or as professionals at any level, we might not be able to make those same connections. The other thing people might not be aware of is that there is a whole separate partner organization called APA Services, Inc., that has greater latitude in terms of their advocacy and lobbying capacity than our 501c3 educational side. So by channeling our research, our professional experiences, our issues, arguments through the APA system, we can sometimes inform and support efforts being taken on the APA services side that aren't Society for Health Psychology per se, but it informs that work in some of the same ways that Dr. Bruns demonstrated. He would inform different organizations and systems about psychological data and evidence that supported changes in the system. So there are ways that we can advocate, and there are even ways that we can lobby. But it's very important for the organization, both for the society and for APA, that we do it in a transparent and coordinated way so that we don't run afoul of our nonprofit status or purpose, and we get the best and most impactful results from the efforts that are being made.
One of the things...
I'll just say, if you're not sure, ask first. We'll check it out for you, and then we can proceed from there. Much easier to prepare for the situation than to back away from it.
One of the things I've found over the years, just a change in my perspective, is when you're talking about gigantic systems, just appreciating how much inertia they have and how long change takes. And a lot of times I thought, here's this great idea, they should just change. And the process may have actually taken 10 years. And so having an appreciation for the time perspective that organizational change takes, and just all the challenges along the way. I remember that our big study that we did, the 15-year-long study, we almost couldn't get it published because it was a legislative natural experiment. There was a political part to the method. And so that almost killed it. Like some reviewers hated that part. And the fact that I lobbied for that bill, I lobbied to promote the scientific method, but being a lobbyist just tainted that. And so it was actually difficult to publish. But I think taking the long view, that ultimately things that work rise to the top and things that don't sink to the bottom. And so taking the long view about the length of time it takes for organizational change, and just to keep after it. And if you have a good idea, it can take root, and there will be opposition. But you just keep coming back, keep pointing out that, here's the science. This is what it says. And as guidelines based more on a scientific method say, this is what you should do. Shouldn't we follow these guidelines? That over the course of time, some of these changes, like in those slides about the Colorado system and all those regulations of 3,000 pages of biopsychosocial laws, that was 25 years. And so I fast forwarded through those slides, but just appreciate the amount of time it takes for massive organizational change. But looking back at the trajectory of my career, you don't see changes from day to day, but the changes over the decades are, I think, astounding. And so you just need to have faith in the process and just keep on doing what you're doing.
Well, on that note, I think that is a good way to conclude today's webinar. I thank you all for joining us today, and for the insights that all of the speakers have brought. I think this is extremely important work that we will continue, and I hope to be reconnecting with all of you over these topics going forward and put in the efforts. So thank you all again for the speakers and those who joined us today. For the CE credit and receiving the credit for attending this event, please make sure to fill out the evaluation link, which you will receive through your email after this webinar. And we will leave the evaluation open until Thursday, October 26th and CE certificates will be sent within 5 to 10 business days after the evaluation period closes. Even though you are not seeking credit, you are still encouraged to submit an evaluation. And then if you do have questions or follow-up comments, feel free to email APA Division 38 at verizon.net if you have any comments or follow-up questions. Thank you for all of the amazing presentations, and thank you to the audience, and I hope you all have a great rest of your day.